Good afternoon. Thank you all for joining us today. My name is Jesse Berg, and I am a partner in the Minneapolis office of Lathrop GPM. And with me this afternoon is my colleague, Julia Ryland, who is also in the Minneapolis office of Lathrop GPM. And we are going to spend the next hour or so talking to you all about the shifting legal landscape of telehealth, a hot topic certainly, and one that has seen lots of developments over the past few months. So before I jump into the presentation, I'm just going to mention a few housekeeping items as we get started here. First, we certainly welcome your questions throughout the presentation. If you do have questions, please submit them using the chat feature, and we will get to as many of them as we can at the end of the presentation. If we're not able to get to them, we'll certainly be happy to follow up with you after the webinar. Secondly, the webinar is being recorded and it will be available on our website Monday afternoon, along with a copy of our slides. And you will all receive a follow-up email directing you to that page on our website. And we certainly welcome you to share these materials with other folks in your organization. And then I'll also note that we have applied for CLE credit, both in Missouri and Minnesota. Follow-up information will be sent to you upon approval. So the first thing I will note is that we do have an ambitious agenda this afternoon. We are going to try and get to as many of these topics as we can. We may skip over or only touch briefly on a few of them in the interest of time. And if we do skip over something that's important to you, please reach out to us afterwards, and we'll be happy to address your questions. So just as a kind of level set to get going, we thought that this slide here might be a helpful reference tool. These terms, you'll hear both Julia and myself mention these a number of different times during the presentation today. And this is essentially what the terms we're referring to. These don't come really from a statute or a regulation. These are basically the commonly understood telehealth terms that we're going to be talking about this afternoon. So let's talk a bit about what telehealth is. All of the reasons you see on this slide here were in place prior to the COVID pandemic hitting the country. Certainly, all of these rationales for using telehealth as a means of delivering care have been accelerated as a result of COVID. And as a result of that, we as providers and attorneys and other individuals who work with providers find ourselves in a position where it can be a bit challenging to understand and implement the statutory and regulatory scheme that governs the operation of telehealth. There are basically two fundamental concepts, both of which are spelled out on this slide here. And then from these two concepts, there are a number of drill down issues. The first concept is essentially, the practice of professional services, whether it's technically medicine or something else. What kinds of services can be provided using this technology? Who can provide the services? The type of technology that's relevant to doing that is kind of the first bucket of issues. And then secondly, what are we doing to try and ensure that reimbursement is made for these services? So from here, you will find yourself in a situation where you are very quickly needing to drill down into a variety of detailed concepts depending on the type of business model at issue. And some of this is very clear-cut. Other issues are not as clear-cut. Certainly the federal concepts, the operation of telehealth in the Medicare program, the regulation of telehealth services under the federal privacy law that we all are very familiar with, known as HIPAA, some of the federal fraud and abuse guidelines. Those concepts do have some standardization. But from there, we start to get into a number of areas where what's permitted in one jurisdiction may not be permitted or may be a bit ambiguous in another jurisdiction. And some of those issues are at the bottom of the slide here. So we're going to be talking about a number of these as we go forward throughout the next hour or so. The very last comment on this slide is a bit of an understatement. It kind of puts it mildly, but really the important thing from a state to state perspective is to remember the guidance can really vary among states, and it can vary pretty significantly among states as well. So all of that was kind of the world we were living in prior to February of this year, when the COVID-19 pandemic hit the United States and also, of course, hit many other places in the world. And it really found a telehealth system that, while it was in operation at that time, it really wasn't used to the extent that a lot of its proponents would hope that it had been used. So as we'll get into in more detail, there were a variety of restrictions under the Medicare program, for instance, that really restricted the availability of telehealth to rural and remote areas, essentially basically making the tool available for situations where patients didn't have another option for getting care. So when COVID-19 hit the country, the regulatory system that was in place at that time found itself really running up against this pandemic and this question of, well, what can we do to try to make care available via telehealth? How can we reduce barriers in a way that permits patients to get services remotely? Obviously, that has a huge benefit when the virus spreads by person-to-person contact. And consequently, our federal regulatory agencies, our state regulatory agencies, governors across the country found themselves in a position where they really had to scramble to try to make changes quickly to make telehealth more user-friendly right away. And we've seen a lot of that happen. It's a pretty impressive set of changes that have been made in a very short period of time, because we've seen changes throughout the level of issues that apply in healthcare. So the Telephone Consumer Protection Act, for example, a variety of waivers, both at the state and federal level, for a vast assortment of providers and suppliers. And when I say providers and suppliers, for now, I mean it in the technical term for purposes of the Medicare program. So we saw, for instance, hospitals, skilled nursing facilities seeing waivers of a variety of the conditions of participation requirements that would typically apply to their operations. State licensing requirements, as Julia will talk about in a little bit, a lot of relaxation there. Certainly the trend in the Medicare and Medicaid program around increased program integrity and enrollment scrutiny, that is not something that works well with trying to get providers into the healthcare environment quickly. So CMS, state agencies really doing a lot to try to make it easier for providers to participate in these programs. And then some of the regulatory guidelines that address financial relationships between referral sources, as we'll talk a little bit about moving forward. Changes essentially to say, look, provider community, we understand that you all need to cooperate in unprecedented ways during this pandemic. So we're going to apply some of the key laws in this area, the anti-kickback law and the Stark law, which we'll talk about more later, really focused on financial relationships between referral sources. We're gonna apply those laws in a less strict way for the time being, so that providers have an opportunity to cooperate. And then other changes involving Drug Enforcement Administration and controlled substance prescriptions made online, and certainly HIPAA and the requirements under HIPAA for sharing information electronically. A lot of flexibility introduced there as well, and we're going to come back to these, so I'll skip over them for the time being. So all of that has been happening over the past few months, and it's really had the impact among many in the healthcare industry of really begging the question of, well, what's going to be the permanent solution to this issue? Because no one knows when this is going to end. We all hope it will end soon, but so far it doesn't seem like there's a lot of certainty that that's likely to happen. And providers, payers, people who work with providers and payers are all wondering, what is the long-term game plan here? And so this debate has been bubbling around for a little bit. Just this week, we saw a couple of important developments. One, a little bit less important, but an executive order from the White House essentially directing CMS to try and propose additional regulations that would expand Medicare coverage after the expiration of the PHE, which means public health emergency, and that's the state of emergency that Secretary Azar has declared nationally that we're all living in. And then secondly, and more importantly, is the publication of the proposed regulations under the Medicare physician fee schedule for 2021. And we're going to talk a bit about this, the proposed regulation going forward, because it's pretty interesting. A couple points on it at a higher level that I'll note. Technically, this hasn't actually been published yet in the Federal Register. There's a pre-publication version. We have a link to it at the end of the presentation here, and it will be published in the Federal Register on August 17th. So you can look for it then, or you can review it now. It will be exactly the same. It's just that the pre-publication version is a lot longer due to the way they format it. So if you hit print accidentally, you're going to wind up with 1,400 or so pages at your printer of regulations. And the important thing, or one of the important things about this proposed rule, is that it's proposed. So that sounds obvious, of course, but basically what that means is the Department of Health and Human Services looks at this proposed rule, like it looks at all proposed rules, as an opportunity to get feedback from industry on what the agencies are talking about doing. Now, Health and Human Services has been very clear over the years that if they don't get relevant feedback from industry, they're not going to understand the implications of their proposals on the provider community. So they really want organizations to provide feedback. And they really warn against the perception that a lot of times folks might have, which is, I don't need to say something here because someone else probably is going to say the same thing. And the problem, of course, is that if everybody takes that approach, we don't get any feedback going back to the regulatory agencies. So they really want comments. We've got several months. We've got about 2 months to submit comments on this proposed regulation. And you're probably wondering, well, how would I go about doing that? Well, it's actually very simple, and it's much more straightforward than it used to be. The link here at the top of this slide will take you to the webpage you can use to submit comments. And the bulk of this slide basically is just a screenshot of a frequently asked question about how the comment process works. So, if you hear anything today or later on in your reading or other seminars or events that you attend talking about this proposed rule that is of interest to you, whether you think it's a good idea or a horrible idea, we really encourage you to submit comments if you are so inclined. And with that, I am going to turn it over to Julia, who is going to dig into the first issue we're going to talk about this afternoon.
Thanks so much, Jesse. So thanks everybody for joining us. We're going to just jump right into some of the key legal issues that we wanted to cover today, the first of which is going to be licensure and scope of practice. So for those of you who are listening in today that have either kicked off your telehealth program or has had it under operations for quite some time, you'll know that licensure and scope of practice tends to be one of those foundational issues that needs to be addressed. We're going to talk just a little bit about what that means. So the general rule with respect to licensure, of course, is that a provider must be licensed by the state in which the patient is located. So when you're talking about a telehealth program here, we have the patient located in one state, the provider in a different one. Typically, it's what states say is that the provider needs to have a license in place where the patient is located. And this is true because most states define the practice of medicine based on where the patient is located, and that's typically how licensure rules are governed and tied to. But that being said, a lot of states actually permit providers to obtain permission to render care in ways that are less burdensome than obtaining a true full license. So if you're looking at licensure issues, you should be looking for things under state law that have to deal with, a special telemedicine license or a special purpose license, even a registration. And the benefit of these is that it really eases some of the administrative burdens that go along with getting your providers to operate in other states. Just by way of context, we have typically about 49 states, I think is where we're at right now, that say that the licensure needs to be in place where the patient is located. Of these, 12 do require or have the option of a special purpose license or some sort of special telemedicine certificate. And then 6 state boards offer a registration option. So there are things to look for that can make the process a little bit easier. In Minnesota here, we do have a registration option, so it's a little bit easier to be able to provide those telehealth services. The other thing to look for is a lot of states have a consultation exception that allows providers to consult and provide medical services that way. The thing to know here is that the exceptions across states vary a lot, so you should be careful about what you mean or what you're looking for in terms of the services and the consultations that are being provided. Minnesota, just to give you an example, does have this kind of consultation exception, but it requires that the Minnesota physician retain ultimate authority over the patient. So that's just to give you a sense as to how these rules sort of play out. As I mentioned, the state terminology and definitions really do vary across the board. So oftentimes the reason that licensure is tied to where the patient is located is because of this definition, but it can often be broader than this. So certain actions may actually constitute the practice of medicine if they're performed within a particular state, even if that's not where the patient is. So an example of this is Massachusetts, where we have a specific reference to the fact that providing telemedicine in Massachusetts constitutes the practice of medicine, which means from a practical perspective that you'll have to likely be licensed both in Massachusetts and where the patient is located. There are a couple other examples of this, Virginia and Mississippi. So that's another key issue to look for. Of course, with COVID, we have some changes that have happened for the better. That's made it a little bit easier. So the big one to know is that CMS did waive the licensure requirement as long as the provider is licensed and in good standing in another state. So that creates a lot of flexibility on the federal level, but the key here is that it's limited in scope, right? Because it's CMS. So it's limited to conditions of participation and payment for federal healthcare programs, and which ultimately means that it does not supersede state licensure requirements. So from a practical perspective, even during this pandemic, to be able to provide telehealth services, practitioners still have to comply with applicable state licensing rules. So they either need to be licensed or go through one of those special purpose licenses or registration process, or there needs to be a state waiver in place that waives the licensure requirements. Many states have enacted waivers. The nuances of them vary, of course. We've included some examples here from Minnesota just to give you an idea. The thing to watch for is that states are taking their own approach to licensure waivers. So some have done a full waiver of a licensure requirement. Others have implemented sort of an expedited process or a simplified form. The other issue that we wanted to touch base on was the scope of practice. So one of the first questions when you're providing services is how to establish a provider-patient relationship. And when you're thinking about this in the context of telehealth, it gets a little complicated because some questions arise as to whether you need to actually have an in-person contact to establish that relationship. Many states say that that's not the case. In fact, Minnesota explicitly says that a relationship of this nature can be established solely through telemedicine. but it does raise some important issues, one of which is whether a provider will have the same ability and the same opportunity to choose whether to treat a particular patient. So the ability to sort of, redirect or direct patients could very well be limited by technology and the business model that you adopt. The takeaway is ultimately providers that do provide telehealth services are subject to the same standards of practice and conduct, even as if those services were provided in person. So scope of practice requirements, of course, still need to be met. You're generally going to be looking at the practice standards of the state where the patient receives care. So you need to be thinking about what those state rules are around the scope of practice, what various license holders can do, what supervision requirements need to be in place. And the provider is ultimately going to be the one driving those questions. Requirements are going to vary for physician providers as compared to non-physician practitioners. They're going to vary in terms of how that state defines telemedicine and whether there are any limitations on what services can be provided. And they're also going to vary in terms of what the supervision and oversight requirements are. Just to give you another example, so in Minnesota, we do have some rules around supervision of physician assistants, for an example. So on-site supervision of a physician assistant is not required as long as there can be contact via telephone to the supervising physician, which works well in a telehealth model. But other states may not necessarily take that same approach. So you could have a situation where supervision between a non-physician practitioner and a physician looks a little different, even though services are being provided to an out-of-state patient. Some services, of course, will still require an in-person care element. A very common example is prescriptions. So under the DEA here, we had this requirement, which has been suspended during COVID, but a requirement that there needs to be at least one in-person exam prior to the prescription of a controlled substance. State laws often have similar in-person requirements, so Minnesota has them as well. So just watch for those when you're thinking about what services you're offering, which leads us to this next sort of global slide here. When you're thinking about operating a telehealth program, you should really be considering kind of two key questions. Number one, what services are you looking to provide? Can you meet those services under the standard of care? Does state law permit those services to be provided by telehealth? Are there specialty or other particular requirements that are particular to those services? And then who's going to be the provider here? Are we talking about physicians, non-physician practitioners, psychologists, et cetera? All of those are going to be really key questions that arise in the context of licensure and scope of practice. So as Jesse mentioned, there are going to be some potential changes to some of these rules due to this proposed rule that CMS just released. Prior to the May 1st COVID rule, non-physician practitioners were generally authorized under Medicare to order and furnish diagnostic tests. But as a general rule, they weren't allowed to supervise, only physicians were. So if finalized, right now what CMS is proposing, it would allow nurse practitioners and clinical nurse specialists, so forth, to actually supervise the performance of diagnostic tests in addition. So that could be one big change. The other one to know and just keep on your radar is that they're proposing to allow direct supervision to be provided using real-time interactive audio and video through December 31st. So this would be extending it beyond the scope of what's currently being talked about. And there are a couple other changes just to keep on your radar as well. And with that, I'll turn it over to Jesse.
Thanks, Julia. So I'm just going to spend a few minutes talking about the pre-COVID approach to reimbursement under the Medicare, Medicaid programs, and also touch upon that issue for commercial payers. So Medicare has been paying for telehealth services for quite a while now. We just passed the 55-year mark in terms of Medicare's anniversary. It was signed into law July 30th, 1965. And we've had telehealth reimbursement for 20 years, which is quite a while if you think about it. Medicare has been covering telehealth services since about 2000. The problem is that the scope of coverage has been very slow. The growth has been incremental. It started to accelerate a little bit more over the past 4 years or so, but for the most part, it's been pretty slow moving. And we've had a lot of restrictions under the Medicare program's coverage of these services. And again, the reason is when this was announced back in 2000, it was really intended to try to help folks living in rural and underserved areas. So one of the key restrictions in place historically is that patients needed to be located at what was called a qualifying originating site. And that had two components. There was a geographic element to it, which basically meant the patient needed to be located in a rural health professional shortage area. And the patient also needed to be physically present with a provider. So they needed it to be in the office of a physician or a hospital, for example. They weren't able to receive care at home via telehealth. And well, that doesn't make a ton of sense when we talk about it today. If you remember how the internet was back in 2000, it probably seemed a little bit far-fetched back then that folks could get health care from the comfort of their own homes. There were other restrictions as well, and you can see a few of those listed on this slide here. And a lot of these elements have changed recently, which is pretty helpful. The Medicaid program has seen some developments as well. This slide here is a summary of what's been happening in Medicaid. The thing about Medicaid, of course, is that states are really free to set their own approaches to Medicaid coverage and reimbursement as long as they do so within the parameters of specific federal standards. So it's a little more challenging to summarize what Medicaid programs were doing, but this slide outlines some of the different approaches that were taken under various Medicaid programs, and you can see some of the different approaches and different issues covered from state to state. You know, certainly states would take a different approach on the settings where patients could receive care, and this is one example where Medicaid has been certainly ahead of the game as compared to Medicare. As of 2018, we had 29 states that permitted coverage under the state Medicaid program of telehealth-based home health care services, including remote patient monitoring, which we'll come back to a little bit later. That's basically the use of technology to help providers keep track of a patient's condition, so it can be helpful, for example, if you've got a patient who has a heart condition who might need monitoring. So as of 2018, we saw Medicaid far ahead of where Medicare was on that particular issue. Commercial payers, again, a lot of variation because this is very much a state-specific issue. If we look at how things were organized as of 2018, by that time we had 31 states in the District of Columbia that had some version of either or both of what we call telehealth commercial payer laws and telehealth parity laws in place. And essentially those are kind of the two concepts that are used when we discuss commercial payer reimbursement of telehealth services. The idea with the coverage laws, essentially, states might pass a law that say to the health plans, look, you need to cover services rendered via telehealth to the same extent that you would if those services are provided in person. And then the second component there is the concept of payment parity. And essentially what's happening here is that providers will be paid the same amount for services rendered via telehealth that they would be if the services had been paid in person. Now, all of this, of course, has changed dramatically when COVID hit the country. This slide here is intended to try to give a bit of a summary of some of the sources of these changes. We've seen a number of different developments at the Medicare and Medicaid level. The CARES Act, certainly a statutory change, separate regulations, two different final rules under the CARES Act, then another set of regulations under the Medicare Advantage program. And all of that's in addition to the various waivers that we've touched upon. And as you can probably guess, it's a bit of a, it can be a bit challenging for industry to keep track of all of these things. I think it's been challenging for the agencies to develop all of these rules. They've certainly done a really commendable job in tackling a lot of complex issues in a very short period of time, and really striving to try to put as much information out there for industry as they can. This slide here has a link to where you can go to get a hold of the telemedicine toolkit that CMS recently issued. And then, as I mentioned before, we've got a number of links at the end of the presentation for other materials as well. So as we'll talk about now, we're seeing some trends under what's happened with COVID, and the trends are summarized at the bottom of the slide here, really expanding services in a variety of ways. Certainly the scope of services that are covered under telehealth has grown dramatically, and you can see a link to go to the page where you can get more information about the scope of services changes in that regard. So what have all of the developments under COVID or as a result of COVID meant for telehealth? Well, really, we've just seen unprecedented growth in the delivery of services in this fashion. This slide here outlines a couple different measures intended to show how much this has grown. Back in 2016, the Medicare budget was over $600 billion just in the year, and Medicare paid out only $28 million in telehealth reimbursement. So just a small fraction of reimbursement for telehealth services. You compare that to how things look currently, and we've seen just a remarkable growth, both under the Medicare program and also for commercial payers. CMS has noted that they covered 1.7 million virtual visits during the last week of April, which is an increase from the previous tally of 14,000 visits. So that increase has been enormous. But it's not just Medicare. There's some fascinating commercial payer data out there that shows the growth of services. And Fair Health, which is a nonprofit data tracking organization that specifically monitors commercial payer coverage and reimbursement of telehealth services, has noted some pretty fascinating information. We've seen an 8,000% increase in telehealth claims from April 2019 to April 2020. So just, remarkable growth. Fair Health also breaks down growth by region, and in the Midwest region where Missouri and Minnesota are located, we saw the increase in claims for telehealth services go up from under 0.2% of total claims to almost 11% of claims, which is an increase of over 6,700%, again, measured from April 2019 to April 2020. And you can also find out the kinds of services people are getting via telehealth, and mental health is by far the biggest increase. Mental health claims represent over 40% of telehealth claims that commercial payers have reimbursed under COVID, and that's more than 10 times higher than the next closest category of diagnoses. So as a result of all of that, as I mentioned earlier, there's been tons of pressure from industry to make some permanent decisions around coverage. That kind of came to a head at the end of June when a letter that was signed by more than 340 organizations was submitted to leaders of both houses of Congress. It's really a remarkable group of heavy hitters signing this letter from all sectors of industry. We had academic medical providers, USC, Michigan, Duke, Indiana. We had enormous industry associations like MGMA or AdvaMed. We have tech companies like Intel and Google, and then large healthcare systems like Marshfield Clinic and Mass General, all coming together and basically saying to Congress, look, we need to do something permanent on this issue. And we've seen a bit of a reaction, and that's the proposed regulation that we're going to talk about in just a second. CMS is aware of this as well. This slide here is data from CMS looking at growth in telehealth in primary care. This looks at the 15 most populous urban areas in the United States and tracks primary care visits, back in February rendered via telehealth, and then looking at how those visits were occurring in April. You can see Minneapolis, we shot up from 0.1% in February. We're now at about 64% of visits, primary care visits, are being done via telehealth. And what's really remarkable about this is there's a correlation here, or a question of correlation here, in terms of whether this is happening only in states where we have high rates of hospitalization for telehealth. And you can see with Minneapolis in particular, we're doing this even though we're very low, or we were at least when this slide was published, in terms of hospitalization for COVID. So our provider community is really, doing its utmost to expand these services. So what has Medicare been doing both in the pandemic and in the proposed rule? Julia already talked about the licensure issues, so I won't spend any time there. But in terms of reimbursement, we've seen a lot of changes. CMS has basically put on hold some of the major roadblocks to rendering services via telehealth. The restrictions I mentioned before, that patients need to be located in rural areas, that they need to be with an in-person provider at a facility, that the patient cannot receive healthcare services at home. All of those things have been waived for the time being. Another important change, federally qualified health centers and rural health clinics, they've been prohibited historically from functioning as distant site providers in the telehealth program under Medicare. And you probably wonder, well, why would that be? And the reason is because there's, the list of providers who can bill for services under Medicare is governed by statute. And our federally qualified health centers, rural health clinics, I don't think they were regarded the same back in 1998 when the statute changed. So they've been excluded up until now. That's also been put on hold during the pandemic. Medicare has also dramatically expanded the list of services that are covered. 135 additional services can be provided via telehealth under the Medicare program. There's a link earlier in the materials where you can go find those slides. The Medicare program has also waived a lot of the restrictions related to face-to-face requirements and said to the provider community, look, you can use telehealth to render these services. So home health, hospice certifications, for example, require face-to-face visits during the pandemic. This is something that can be provided remotely using telehealth. And then a variety of other changes as well. Equalizing reimbursement rates for services as if they were provided in person, expanding the ability to provide audio-only telehealth services under Medicare. So that's phone calls, essentially. Waiving a lot of the requirements that establish frequency of service limitations for certain types of services. Those are all changes that have been made as well. So will these changes be made permanent? Well, it's a fascinating question, and the proposed rule intends or is designed to try and do that quite a bit. It takes a threefold approach to addressing the issue of coverage under the Medicare program. First thing it does is it proposes to cover a number of services permanently under Medicare that can be covered via telehealth during the pandemic. And I've listed some of those services on this slide. So for example, home visits, home care visits, group psychotherapy, adding complexity codes for certain office and outpatient evaluation and management services. Those are all things where CMS is proposing to make those changes permanent. The second prong in what CMS is proposing to do is they're basically saying, okay, for services that we're covering now as a result of the pandemic, what we're going to do is we're going to agree to continue to cover those services through the end of the year of the year in which the pandemic or the public health emergency ends. So if the public health emergency ends in 2021, CMS under this proposal would cover all of the services that are temporarily covered under Medicare through the rest of 2021. And then the third thing they're doing is they're saying, look, we want feedback from industry about whether we should cover more services. So this is an example of the kind of thing where it would be very helpful to provide comment if you believe that there should be additional services that are covered under the Medicare program. So for example, a good, I point on that would be audio only evaluation and management services. CMS is wondering if they should develop a new coding and payment system for these services intended to take into account the complexity that can arise. And that's an area where they're looking for feedback. Or remote patient monitoring. This is what we mentioned before, which is using technology to track and monitor patient conditions while the patient is at home, which is a great way of preventing problems. Well, historically, Medicare only covered those services for patients who had chronic health care conditions. During the pandemic, that's been expanded a bit to cover, in addition to patients with chronic conditions, patients who have acute care conditions. So CMS is wondering, should we continue to do that as well? So again, great areas for feedback to CMS on those points. A variety of other changes in the proposed rule outlined on this slide. They're wondering about permanent relaxation of frequency visits or frequency limitations for certain services provided via telehealth. So if you're a patient in a skilled nursing facility, traditionally under Medicare, only one visit every 30 days what was covered. The question now is whether we should cover one visit every 3 days is where they're looking for feedback. Or another area where we've seen an expansion of coverage in academic medicine has to do with the ability of teaching physicians to use telehealth to supervise performing services, resident physicians performing services. Also expanding the set of services that residents can cover, expanding the ability of residents to moonlight outside of their graduate medical education program. All of those historical restrictions have been waived during the pandemic or relaxed during the pandemic. 2021 physician fee schedule wants feedback on whether those changes should be made permanent going forward. The Medicaid program, the quality payment program is another area where we've seen some proposed changes. And now this is really important for providers because as many folks on the phone probably know, the shift to value-based reimbursement that we're seeing at a federal level is basically saying to providers, look, you need to report on quality metrics, and if you do a poor job on quality metrics, you are eventually going to see your Part B reimbursement cut. So if Medicare will pay $100 for a service, provider who's a poor performer under CMS's quality payment programs might only get $92 instead of $100 for that service. CMS recognizes that what's been happening with the pandemic has thrown wrenches into providers' ability to report on these metrics, and they're proposing now to delay a lot of these changes for the time being, and also to try to increase some payment opportunities, some bonus opportunities for providers who are seeing patients with complex conditions due to COVID. So really the takeaway here is to try and help the provider community essentially get more of an opportunity to receive traditionally higher Part B reimbursement and not be penalized as a result of COVID. Medicaid, we've seen a number of changes in Minnesota, certainly. This slide here goes through quite a few of them. This is all from the Department of Human Services. Basically, Medicaid program in Minnesota has expanded services that it will cover under telehealth. Historically, for example, there was a limit of 3 telemedicine encounters per week. That's been suspended. Distant sites, the provider's location under Minnesota Medicaid can be the provider's home. The patient can receive services at home. DHS has also expanded the use of telehealth under a variety of specific programs. So under the home and community-based waiver services programs, for adult daycare providers, for targeted case management providers. All of those categories of providers have seen the expansion of coverage under the Medicaid program in Minnesota. Commercial payers, a number of changes as well. The Minnesota legislature has already taken some actions related to commercial payer coverage of telemedicine or telehealth services, and you see some of those changes at the bottom of the slide here. All of these changes are set to last through February 2021. Currently anyway, and we'll see if there are future developments there. Other states are taking similar approaches, but again, generalizing from state to state can be a bit challenging. And then the last thing I'll say before we shift over to privacy is, what about enforcement? Generally, the regulatory agencies have said in a variety of ways, look, we're going to be a little bit more relaxed about enforcement during the pandemic. So that is helpful. I think providers are doing their best to comply with things, but it is unprecedented situation that we're in, so it can be challenging to figure out how best to do that. We are starting to see some enforcement activity specific to telehealth. All of this predates COVID, but it is worth noting because when the OIG puts out reports talking about how people are not billing in accordance with the billing rules, or potentially saying CMS isn't doing enough to perform oversight of providers, that tends to get CMS and other agencies motivated. And we saw a report just like that in 2018 where OIG said, look, over 30% of claims billed to the Medicare program for telehealth services did not comply with the billing requirements. So, they're basically recommending that CMS and the Medicare administrative contractors take a more rigorous approach on compliance. We did a whole seminar in conjunction with MGMA a few weeks ago, where there was a lot of focus on fraud and abuse and compliance issues in the context of telehealth. If you're interested in those slides, send us an email and we'll be sure to get them to you after the presentation. And with that, I will turn it back over to Julia.
Thanks, Jesse. Okay, so we're going to just shift focus a little bit and talk about privacy and security. It's another really important issue when it comes to telehealth programs. Of course, it comes with no surprise that providers are going to be required to comply with both federal and state privacy and security requirements. But the key here is that in a telehealth situation, of course, you have different technology being used, different vendors that are involved. So it becomes a little bit more complex to comply with these requirements. Providers have to be sure that they're using a HIPAA compliant platform when it comes to technologies, and then take that into account in addition to the state law requirements that may lay on top of that. So the first thing that we typically recommend providers do is to take a step back and to think about the technology that you're going to be using in your program here, and then what players are going to be involved. So of course, the healthcare provider is going to be a covered entity under HIPAA, which means that the provider is going to have to comply with the privacy and security rules. And we're going to talk just a little bit more about that coming up here. The key, though, is the vendors is going to play a bigger role in this program. So vendors typically will constitute a HIPAA business associate. And this is because oftentimes when you have a telehealth program, you have a need for some sort of vendor, some sort of technology that either functions or provides services to the provider to help deliver that service. And if that vendor has access to patient information, then the business associate rules under HIPAA are going to be triggered. There's a narrow exception for a conduit, which we can talk about. It's a pretty limited exception to the definition of the term business associate. And it typically only applies to organizations that function as a transmission-only service provider. So that means that perhaps they have access to PHI on sort of a transient or temporary basis, but they don't otherwise store or maintain that data. So sometimes we get into these questions when it comes to, email providers, or other sorts of questions where the PHI is really just shifting through from point A to point B. And there's questions around whether that means that that particular vendor can constitute a conduit. It's a complicated analysis. It's very limited is what we'll say, but it's something that can be worth looking at. When it comes to patient populations, of course, they're entitled to the same rights as they would when it comes to inpatient care. So access rights, HIPAA authorization, state consent requirements, minimum necessary, all of those will continue to apply. From a privacy rule perspective, there's a few kind of key questions here. So think about what patient data is being transmitted and what it's going to be used for. Is it treatment only? Is it research? It really will vary depending on the type of services that are being provided. This will flow into issues related to patient-informed consent and authorization. One thing to really note is that it could be the case, if you haven't done so already, that you need to update your notice of privacy practices. To have a truly effective notice of privacy practices, you do need to describe your telehealth program so that patients who participate in this understand how information is being used and shared. So that's something that you need to watch for. There's also good questions about what's being done to prevent unauthorized disclosure of PHI. So this raises a lot of practical issues with respect to video and audio technology. If there's any risk of transmitting it to the wrong party, are there other individuals, who have access or who could overhear or see the visit that's happening that would exceed the authority under HIPAA? All of those are really good things that you need to be thinking about. And then, of course, as we mentioned, thinking through the various companies and vendors that are involved in your telehealth program. So thinking through the storing and transmitting of the PHI and making sure that those vendors that do have access to PHI have BAAs in place, a business associate agreement, and potentially exploring, the vendors' downstream subcontractors. So to see if there are subcontractors at the technology level that may have access to PHI and that there are appropriate agreements putting protections in place for that relationship as well. From a security rule perspective, we need to be thinking about, again, how we're protecting against unauthorized uses and disclosures. This raises a lot of questions around device security. So have you done a risk assessment that really assesses what devices are being used and what technology protections are in place? So those are all really good things that need to be addressed. We need to think about things like encryption and what the vendor is doing with respect to HIPAA, as we mentioned, those downstream relationships. But from a practical perspective, the challenge with telehealth is often that providers and patients really don't understand what the technology, what risks come with that, which requires you to have, of course, under HIPAA, really good training on the provider level. So you need to make sure that providers and staff are appropriately trained on these technologies, understand what requirements apply to them, and that the same sort of HIPAA protections that you would use are put in place. Things like password protections, no sharing of passwords, unique user IDs. All of those will continue with respect to the various devices that are being used. As it's a trend that we've been saying here. So of course there have been changes and updates with respect to COVID. So CMS did issue a waiver that permits the use of smartphones with audio and video capability that will facilitate these telehealth encounters. And then just as Jesse mentioned a bit earlier, we also have some enforcement discretion statements being issued from OCR. So OCR has said that they will exercise enforcement discretion, essentially meaning that they're not going to issue HIPAA penalties for violations that occur during this pandemic, when the provider is really serving patients in good faith, but using everyday technologies that may not comply with HIPAA. So these are technologies like FaceTime or Skype, all those things that we use all the time, Google Hangouts or Zoom. So they may not be HIPAA compliant technically, but OCR is going to choose to not make HIPAA enforcements with those systems. The thing to know, though, of course, is OCR is of course still saying that providers, you need to notify patients that there are risks involved with these, and you need to be putting them on notice that by having these, these visits through these systems, they're going to be assuming risk that they may not otherwise be used to. And the OCR is still encouraging providers to work with vendors that are HIPAA compliant and get those business associate agreements in place. And with that, I'll turn it over to Jesse.
Thanks, Julia. As we are approaching the end here, I'm going to accelerate pretty quickly through a lot of this. The first few slides here are just a refresher on some of the key fraud and abuse principles. You know, they apply to telehealth just like they apply to other services. There can be some unique risks that we'll talk about in just a second, but certainly our anti-kickback statute, our Stark law, the civil monetary penalties law, which is really about inducing patients to get services and potentially providing the patient something of value to obtain services. All of those are relevant in the telehealth world. Occasionally, we will have providers who try and avoid the scope of federal fraud and abuse by more or less carving out Medicare and Medicaid patients and trying to do some version of a commercial or private pay-based arrangement. That can work. The important thing, though, is that, you know, all states have some version of an anti-kickback statute or a fee-splitting law. Those laws can be pretty extensive in scope. So, you know, just because you don't have Medicare or Medicaid in your program, don't overlook the state laws. This slide here has a few points on that topic. The fraud and abuse laws that are relevant to telehealth arrangements, they really can vary. This slide is intended to illustrate how a few fraud and abuse issues might pop up in a provider-to-provider model that's pretty common. So in something like this, we've got a distant site provider and an originating site provider. They might have a collaboration agreement where, for example, a patient has surgery in a hospital in a large urban area, goes home. There needs to be post-discharge consults, and perhaps we can use telehealth to make those services available from our distant site provider to the originating site provider. Can you do that? You certainly can do that. You know, the scope of the arrangement can present some issues. One of the most common things that comes up is where we'll have a distant site provider who might want to make technology available for free to the originating site provider for purposes of facilitating this arrangement. And that can work if the technology is used only for purposes of the arrangement at issue. Where it starts to get more complex is where the originating site provider might be able to use that technology for services that have independent value to the originating site provider. But as I'll talk about in a second, OIG has actually blessed that temporarily during the COVID waiver. I won't spend any time on the next one. It's really just intended to try to illustrate the potential issue of inducing the beneficiary to obtain services via telehealth. CMS for the Stark Law and Office of Inspector General for the anti-kickback statute, they both have taken a number of steps to waive the application of anti-kickback and Stark for the time being. There are very broad Stark Law waivers, 18 separate waivers, and to fall within them, the purpose of remuneration basically needs to be in pursuit of one of 5 COVID purposes that you see outlined at the bottom of the slide here, and then you'll fit within one of the 18 waivers. The waivers themselves are fairly broad. One example that's relevant, CMS has basically said you can have a DHS entity providing free telehealth equipment to a physician referral source as long as it's used for purposes of social distancing in compliance with the Stark Law waiver. OIG is taking a similar approach with the anti-kickback statute. They basically said that anything protected under the Stark Law waivers will be treated as protected under the anti-kickback statute. They've also come out and said that they will not enforce the anti-kickback statute or the beneficiary inducement prohibition against cost sharing on patients. So you can waive those payments, those payment requirements to patients during the pandemic. OIG has also taken a new approach where they're publishing frequently asked questions, basically to try and help providers get answers to complex anti-kickback and civil monetary penalty questions. This is not quite the same thing as an advisory opinion, but it's almost as good. It's like an accelerated advisory opinion. And this is one example. This is the one I mentioned a second ago, where a hospital wanted to provide free telehealth equipment to a physician group. The physician group could use that equipment to provide services. They could bill payers and receive reimbursement for it. Traditionally, that would create some issues under the anti-kickback statute, but OIG is blessing it for the time being based on the factors that you see on this slide here. Another helpful example, the OIG has also blessed an arrangement where we had mental health and substance use disorder providers agreeing to pay for cell phones, data plans, and cell phone service plans on behalf of patients, so long as the arrangement could fit within the parameters of this slide here. The last thing I'll say here is all of these developments are occurring in the midst of a separate rulemaking from late October on Stark Law and anti-kickback statute, and basically an attempt to modernize those laws in a way that comply with value-based reimbursement. There are specific exceptions and safe harbors related to telehealth in the proposed regulations. I won't spend time on them now, but we do have an entirely separate presentation that Julia and I did all about these proposed rules. So if you'd like a copy of that, please email us and we will get it to you. And I will turn it back to Julia to just talk quickly about business models.
Thank you, Jesse. Yeah, so I'm going to provide some really quick background on these, on just some very common business models that we tend to see in various telehealth programs. So we have the first one, provider monitoring of patient data. This is going to raise a lot of the same things that we've been talking about, a lot of issues. And primarily what Jesse and I were hoping to do, I see that we're at time here, was we knew that we had a very ambitious agenda. So we wanted to make sure that the slides were going to be of use. This is such an important topic, particularly in today's environment and all the issues that we're dealing with. So our slides have a lot more content on them than what we're spending time talking about. So what we've done here is we've highlighted 4 models that we commonly see in telehealth arrangements and included some various issues that need to be considered, both with respect to the HIPAA, privacy and security, regulatory considerations, and liability. So I won't spend too much time on these just to be respectful of everybody's time. I know that we're all sort of zoomed out and have had a lot of this remote viewing arrangements happening these days, speaking of telehealth services. So I'm going to leave it at that, and we can just kind of include it in your slides presentations to talk about later. The thing that I do want to highlight, before we turn into future guidance here, is one thing that we haven't touched base on that should be on your radar is thinking through some various liability considerations. So as I mentioned earlier, the standard of care is going to be the same. And a lot of issues can arise when you're dealing with various technologies. There's questions that happen about duty to verify and accuracy of information. There are issues when it comes to whether you're inputting data correctly, whether there's auto corrections happening. There's issues with respect to connectivity. And all of these things can raise some malpractice or some liability concerns. So that's something that should really be on your radar when you're considering or evaluating your program, to make sure that you have coverage in place that's going to be sufficient and adequate, particularly when you're doing some of the consulting, because that can make some unique situations even more confusing if you have different providers involved in the same patient care across state lines with different malpractice standards. So just make sure that that's on your radar. And then I'll turn it to Jesse just for a few minutes on the guidance and future developments.
Thanks, Julia. And so, the last thing we'll say today before letting you all go is that obviously we've got a lot happening in this territory. The proposed rule that came out demonstrates that CMS in the meantime has already launched separate concurrent reviews about making some of these changes permanent. So, keep an eye out at the federal level. Certainly more will be coming. There's really no doubt about that. Unfortunately, changing the Medicare and Medicaid rules related to telehealth is not as simple as just issuing some regulations. The way the Medicare statute works, a lot of these requirements to change them will require congressional action. The middle of the slide here gives you some examples of that. So, the parenthetical about waiving these requirements during the public health emergency. That can work for the time being, but when the public health emergency ends, the statutory requirements will snap back and we'll be stuck with some of these same restrictions. And who knows whether Congress will be able to move forward and make a lot of progress in this area, but certainly there is a pressure for that to happen. And then finally, this very last slide here is a link to some of the things that we've been talking about and some of the materials that have been pretty helpful. Encourage you to take a look at those. Thank you so much for your attention this afternoon. I apologize we went a few minutes over. You are more than welcome to contact either one of us at any time about any of the things we've been talking about today, and we will do our best to answer your questions and get you the materials that you need. So thank you again. We really appreciate your attention. Have a good day.